Hello, everyone, and welcome to Achieving Telehealth's Potential, the state policy landscape for interstate telehealth practices. I'm Carmel Shachar, the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School's Executive Director. I think this is a wonderful event to close our exploration of the impact of physician licensure on telehealth and access to care, because it explores state leadership, what challenges and opportunities exist to build interstate telehealth practices. It's a common cliche teaching at the law school that we refer to federalism as the laboratory of the states, but I think in this case, that is really clear that there's the opportunity for some true leadership and creativity in this area. Before we get started with the substance, a few housekeeping notes. We very much hope that you will submit questions because we will be pulling those questions and using them for a moderated discussion with our panelists at the end of the presentations. You can submit your questions at any time. You don't have to wait until the moderated discussion, using the Zoom Q&A feature found in the meeting controls at the bottom of your screen. Our moderator will be reading the questions and pulling them appropriately. You're also welcome to join the conversation or submit questions on Twitter. We're at Petrie-Flom. We will be sharing the fully captioned event video with all registrants, meaning you and other people who registered, within 1 to 2 weeks. And please feel free to share the link widely with friends and family who you think might be interested. If you have any technical issues, on the other hand, please email petrie-flom@law.harvard.edu and we'll do our best to help get you back running. If you like what you see here, I'd strongly encourage you to sign up for our newsletter. It comes out only twice a month, so it will not clog up your inbox, and it's the best way to keep up to date with events, what's getting published on our blog, what our center affiliates are doing in terms of their scholarship. Speaking of our blog, I'd also welcome you to check out Bill of Health, which is our blog that translates cutting-edge bioethics, health law, health policy issues into accessible conversations. We are about to launch a digital symposium looking at climate change and disability, for example. I'd also welcome you to check out our other events. We have a really robust event calendar. Looking at it, I see we have a great event, Artificial Intelligence in Mental Health, looking at how we can avoid data-driven harms. We are about to start on a 3-part series looking at psychedelics regulation around the world. I think that will be a really interesting and mind-broadening, to perhaps use a pun, exploration, as well as our annual conference is coming up looking at health law as private law, how private actors can influence health policy. With all of that housekeeping out of the way, I'd like to hand you over to our moderator, Dr. Ativ Mehrotra, who is Professor of Healthcare Policy at the Department of Healthcare Policy at Harvard Medical School and Associate Professor of Medicine and Hospitalist at Beth Israel Deaconess Medical Center. The floor is yours.
Well, thanks, Carmel, and very excited to wrap up our series and turn to the states. You, I think, really nailed it with the amazing degree of experimentation and different reforms that are being considered at the state level to try to address some of the new challenges we've faced with telemedicine across state lines. What I wanted to do is just take 2 or 3 minutes just to frame the conversation and then turn it over to our amazing panelists. Maybe just to emphasize the point about the different reforms. And there's a lot of shades of gray here, but we're seeing states pursue strategies of reciprocity, where you give physicians in another state or other clinicians in another state automatic licenses in your state. That could be done across all states, or as it was done during the pandemic, but also regional compacts, which we'll hopefully hear about more as we move forward. We can make it easier to get a license, a full license in your own state through joining a compact. And we're going to hear a lot about compacts and their various themes. A number of states have said, well, what we'll do is we'll offer a special form of license called a telemedicine only license, which will allow physicians or other clinicians in another state to provide care, and that this will be less costly or administratively burdensome. And lastly, we're seeing a lot of action in terms of proposals, as well as some states implementing exceptions. So saying you need to be licensed in our state to provide care, except if, for example, the care is for a patient who's traveling or follow-up care, or we're going to limit the number of consultations. And it's really exciting to see all these variations. What I'm hoping we can address through our panelists and our Q&A that comes afterwards is what's driving this amazing diversity across different strategies, to explore to some degree the strengths and weaknesses of these different strategies. Is there an optimal strategy? And what does that mean for the different parties that are going to be impacted? State regulators, payers such as Medicaid, clinicians, and patients. And maybe specifically around the compacts, where there's an amazing amount of diversity across different clinical types of clinicians. Why is there that variation? And is there an optimal kind of compact that we could consider? So to try to address these and other questions, we again have some amazing panelists. I'll briefly introduce them, but their detailed bios are available on the website, and I encourage you to look at their amazing background. We're starting with Dan Logsdon, who's the director of the National Center for Interstate Compacts at the Council of State Governments. After that, it'll be Lisa Robin, the Chief Advocacy Officer from the Federation of State Medical Boards. Hamie Towerson, the Executive Director of the National Academy for State Health Policy. And last but not least, Shannon Dowler, the Chief Medical Officer of North Carolina Medicaid. So let me stop there and pass the baton on to Dan. Thanks.
All right. Thanks, Atif. Let's see, it's saying I can't. Okay, there we go. Thank you. All right. With hope everyone can see that. Thanks, everyone, for having us today. My name's, as Atif said.
Hey, Dan, I don't see it if others may not. Maybe it didn't come through.
I don't know what I did. There we go.
And Dan, right now we're seeing your, oh, there it is. Perfect.
Yeah, I mean, third time's the charm. Thanks, everyone. Appreciate being invited today. I've got some slides to run through. Don't worry, I'm not going to speak to every one of them. I wanted to include them in case when they're shared out, that's more information. Dan Logsdon with the Council of State Governments. I run the Interstate Compact Center here. Just a little bit about CSG. We are a nonprofit membership organization for states. We're non-partisan. Every state's a member. Most of them pay their dues. We serve all three branches of government. That's sort of a unique feature for us. We created the Compact Center back in 2004. We've been working on interstate compacts and multi-state agreements since we were founded in the 1930s. And we're probably the only organization that kind of takes this up as a policy area, but we don't own interstate compacts. There's a number of interstate compacts that CSG has had absolutely nothing to do with, especially the ones that are more politically tinged, but certainly all the national compacts that have been created in the last century, CSG has played some role in those compacts, especially the occupational licensure compact. So you're probably thinking, well, what's an interstate compact? You're not alone. In that, a great example of an interstate compact that you probably didn't know was an interstate compact is your driver's license. So the federal government didn't enact a law that says, you can drive from one state to another seamlessly. It encourages states to work this out for themselves, and they did that. And that is why you don't have to stop at a state border and get permission to drive in another state. These things are tools of the legislature. They're enacted into statutes. They have to be signed into law or allowed to become law by a governor. They're very powerful because they're binding, and states can't pick and choose, like with a model law, for instance, areas that they like or they don't like. There can be no substantive changes once it gets to the legislative process. So, from that standpoint, it is kind of take it or leave it. All modern compacts have interstate commissions that can write rules to sort of interpret the compact, but it can't act outside the four corners of the document. So again, states, there's about 265 interstate compacts that exist. They've been around since the founding of the Republic. In the early part of the 20th century, states began using them for administrative functions. The first modern sort of regulatory administrative compact is actually the New York, New Jersey Port Authority. It turned 100 last year. All right, and so these are just the existing occupational licensure compacts that I want to get into today. Here are the ones that aren't operating, but they're in the process of becoming active and issuing, privileges in this case, and they're out to the states getting more enactment. These are compacts that we're developing, most of them under the auspice of Department of Defense Cooperative Agreement. All these licensure compacts have provisions for military spouses. DOD likes that. It provides regulatory certainty. Every state has enacted numerous laws to benefit military spouses, but they're all different in many ways. So that's why DOD likes compacts for the point of, addressing licensure for military spouses. The Physicians Assistants Associates Compact, we're actually working with the Federation of State Medical Boards. They have a HRSA grant to develop that compact, and we are working with them on that. So with regards to, why compacts have addressed licensure, the first licensure compact was actually created by the nurses about back at the turn of the century. In light of a lot of things that are being talked about and happening today, it's not been that long ago that these licensure compacts were kind of seen as radical. Now they're becoming less so. But states look to them for a number of reasons. One, they wanted to forestall any sort of federal intervention, especially after the North Carolina dental decision. If these compacts protect state sovereignty, under all these licensure compacts, you're required to follow the law in the state where you're practicing. In most of them, it's where the patient is. They wanted to improve licensure portability because they were getting a lot of pressure from the federal government. I think the only area of policy that the Obama, Trump, and Biden administration has anywhere close to an agreement is that licensed professionals ought to be able to travel among states much easier. And then just generally, the only reason you license a profession is to protect the public. So it preserves that and it reduces the social cost of licensure because licensure can be expensive. So we create these through a collaborative process. This isn't just a couple of people in a room writing a compact. We bring together, legislators, state boards, membership associations, practitioners. It takes about a year to get one of these drafted. And then it takes about 2 years before they can meet their requisite number of states and start operating. And then it takes another 18 months typically for them to get stood up. So one of the drawbacks to an interstate compact is it's expensive and it takes a while. Now, once they're up and operating, they're built to last, but they're not a quick solution. And I don't want any part of one that's drafted to be a quick solution because again, these are powerful tools and they're binding on the states. States can leave them, but they have to vote themselves out, and sometimes that proves very difficult. I'm not going to spend much time on these next few slides, but these do have benefits for licensing boards. The biggest thing is it preserves their authority to take action regardless of how you're in their state against practitioners who are practicing in their state. For practitioners, again, they get the ability to practice in multiple states without having to be licensed in those states. So you don't bear the burden of paying for those licensure fees. You also don't bear the burden of keeping up with continuing education. And then obviously for consumers, and I've got some slides later on this specific to telehealth, but it does give you greater access to practitioners, so that addresses access to care issues. There's continuity of care. These do have benefits across the board for everyone from the patient to the regulator to the practitioner. It's one of the drawbacks is these are not quick, they're not easy, and they're expensive to create. All right, and just generally about interstate compacts. So this is an area, these licensure compacts, where states are responding. They've enacted over 230 separate pieces of licensure compact legislation since 2016. 45 states, there you can see, have adopted at least one. Utah, Delaware, Maryland, Georgia, Nebraska, and Colorado are sort of the leading states. So from that list of states, it's not just a red state phenomena or a blue state phenomena. You do see a mix. And in fact, Colorado and Utah are probably the two most progressive states out there as far as looking at ways to enhance mobility and address licensure issues. So there's just a heat map that gives you an idea of the states that have joined. Again, these are the compacts that are currently out to the states for multiple legislative sessions. All right, so quickly want to go through the models. So the way these break down is there's mutual recognition, which means all the other member states are going to agree to mutually recognize your license in good standing in either a home state or a qualifying licensure state. The medical compact works more like TSA pre-check. We're all going to get to the same place. It's just through the medical licensure compact, I can get there quicker. I'm still getting a license in all these states. SIPAC relies on a privilege model as well, but it's strictly for telepsychology. It's got an emergency provision for in-state practice, but it's strictly a telehealth compact. So again, all these licensure compact states don't have a bifurcated system where you have to get one license for telehealth and one license for in-person. So the compact covers both. And some of them don't even mention telehealth because, again, there's no need to. So, here why professionals are often looking to utilize telehealth in their practice, consult on special cases and in emergency situations, like I just mentioned with SIPAC. And then again, one of the benefits of telehealth or some of the key benefits of telehealth obviously is it reduces the travel burden. It can give you access to a wider variety of practitioners, which in many cases can remove the stigma from seeking treatment. And again, what I've learned from working with the Psychology Interstate Compact is that, and they have studies to support this, and I'm sure there's numerous ones out there, that, the efficacy of telehealth really is no different from an inpatient experience with a client, which I think a lot of people would question that. But again, there's a lot of data out there to support that, and the psychologists and their compact lean heavily into that and believe they're providing good care through the compact. And we've got two other mental health professions right now with social work and licensed professional counselors that are pursuing compacts. And with that, I'm going to stop. Here's my contact information. And so let me stop sharing and look forward to answering your questions.
Well, great. Thank you so much, Dan, for that that overview. And I'm sure there'll be a lot of questions related to that. Let me now turn it over to Lisa.
Okay, thank you, Atif. And thank you, Dan. It's been a pleasure working with you over the past many years on these compacts. Next slide, please. I'll just begin with a brief introduction of the Federation of State Medical Boards. We have been around a long time, founded in 1912, and really were founded for the concept of sharing information among state licensing boards. We're national nonprofit, and we represent 70 of the state medical and osteopathic boards across the United States, territories, and the District of Columbia. State medical boards are charged by statute to protect the public through licensing and disciplining and regulating more than 1 million physicians, the majority of physician assistants in the country, and a variety of other healthcare professionals that might fall under the jurisdiction of the individual state medical boards. But FSMB offers a variety of services. We have actually no authority over our boards. We are there to support them in achieving their statutory mandates. We provide education, assessment through the United States Medical Licensing Examination. We have a research department and advocacy. We also do quite a bit of policy work, bringing our members together as well as other consultants and experts to look at regulatory best practices in a number of areas. And of course, the area of telemedicine has been a topic that we have addressed by policy. I have been with the Federation for many, many years, and our first policy was in the late 90s that really created a special purpose license, if you will, for telemedicine. And at that time, it was basically pathology and radiology were the two specialties that were really using cross-border practice. Next slide, please. I'll start out with just a brief update on the Interstate Medical Licensure Compact. This was something that the Federation has supported since it was actually born. We began the discussion in 2014. The Interstate Medical Licensure Compact really became operational in 2017 and issued their first license in April of 2017. And since that time, they've issued about 58,000 licenses through the compact, and this map shows we have it has really been embraced throughout the country, and we are hoping to have that map, solid at some point. We do have legislation pending now in Massachusetts, New York, Missouri, New Mexico, Virginia. It was introduced, but I don't believe that is going to be moving forward this year. Next slide. But the boards really, we learned so much through COVID, and the boards were really flexible, and the states really flexible. The majority of states had waivers, so they were able to provide telemedicine without having to get a license. Some states had different processes in place, but I think we learned a lot through that and how it was utilized and how really healthcare we were able to pivot to taking care of patients without them having to come into the office and try to keep folks at home. And so since that time, we've seen a lot of policy work in this area. And as this map shows, there's a lot of activity going on. And Atif mentioned this in his introductory slides. We have a lot of different licensure schemes going on right now. And I think it's going to be interesting over time that as we gather more data to see really what the outcomes are and how we're able to take care of patients and improve access. So you're seeing a number of these models, and we have more specific information that's really a good descriptive of this on our website for you to check out in the future. And we try to keep this up to date. But we do have a lot of different things going on. And one other, this does not appear on this map, but the Uniform Law Commission, as of last July, approved some model legislation that actually it's more of a registration system. It has been introduced in about 3 states, but it has not been enacted in any state. But I think you will continue to see this model promoted certainly through the Uniform Law Commission and their activities. And it really creates a registration system for out-of-state physicians only, but it is limited to telemedicine and would not include in-person care. Next slide, please. So after what we did, we saw the increased use of absolutely phenomenal increase in the use of telemedicine as part of from COVID. And with that, the Federation did establish a work group to start looking at telemedicine. And we brought together not only representatives from the various state medical boards, but we also had representation from the American Medical Association, the American Osteopathic Association, the American Telemedicine Association, as well as the office for the HRSA office that actually has funded much of this work on license portability through the years. So this work group worked over the course of a year. We also heard and gathered data from various sources and came up with a policy to really update our 2014 policy. So this policy, the appropriate use of telemedicine technologies in the practice of medicine, was adopted by our House of Delegates in April of 22. Our House, the way we operate really as each state board has a delegate to our House of Delegates. So this policy was actually unanimously adopted by our House of Delegates. And now you see states that are using this policy and doing their own, looking at what they have in place now. And some have actually already adopted this policy in whole or in part. But the policy basically really recognizes and affirms that telemedicine can improve access and reduce inequities in the delivery of healthcare, and to understand that certain barriers must be eliminated or reduced in order to provide telemedicine services. And we saw with so many millions of people who didn't have access to internet that we were also you had to look for other means of taking care of them through audio only was one system that I think we found that is something that you have to take into account the individual circumstances of the patient you're taking care of. And also to find that telemedicine is only one component to the practice of medicine, but this policy really differs, and it does find that there are exceptions that can permit telemedicine across state lines without the need for licensure in the state where the patient is located. And finally, just that the same standard of care and professional ethics would apply, whether you're seeing your patients in person or virtually. Next slide, please. So the policy also defined telemedicine, and one thing that was really different was that it could include audio only communications, but that they really should only be used as a substitute when the patient is unable or unwilling to access live interactive modalities, or when those audio only interactions are considered the standard of care for the corresponding healthcare services being delivered. Next slide, please. So our new policy really does provide some exceptions, and this was certainly a departure than the previous policies. And those are physician-to-physician consultations, prospective patient screening for complex referrals, episodic and follow-up care, follow-up after travel for surgical or medical treatment, and for clinical trials. Next slide, please. So also the policy provides for continuity of care and referrals for emergent situations, because as what we found during COVID with so many people either displaced or having to stay home, college students certainly come to mind, but the patient should be able to seek with relative ease follow-up care or information from the physician who conducts an encounter using telemedicine. So also that physicians are accountable for this, and that they need to be responsible to refer patients as needed, or when the medical issue requires an additional physical exam or a diagnostic procedure or radiologic testing, but physicians do have a responsibility to their patients to support continuity of care. And also to be sure that when they are terminating any medical care, that they are certainly making arrangements to transition that patient to another provider. Next slide. Well, that's the end of my presentation. I'm happy to answer any questions as we move forward. Thank you.
Well, thanks so much, Lisa. That was great overview. Do encourage the participants to put questions in the Q&A, and let me pass the baton over to Hammy.
Thanks, Ativ. And wonderful to be here. Hi, everybody. I'm Hammy Tawarson. I am just going to tell you a little bit about the National Academy for State Health Policy, just so you get a sense of where my comments are coming from today. So next slide, please. So we are a nonprofit, nonpartisan organization that's been around for 35 years, and we really, our mission is to support state officials to really advance health policy innovations and solutions. So next slide, please. And just to give you a sense, we work with a lot of different types of state officials. So we're not a membership organization. We really function more like a think tank that is supported by grants, which we engage state officials, without them paying us. And it's really across a lot of different areas. And I just wanted to point that out to you all, so you know that we're working with Medicaid directors, Health and Human Services sector secretaries, governor's offices, legislators, insurance commissioners, behavioral health directors, et cetera, which really, I think, provides us with quite a broad view of state health policy and all the different levers that states are pulling in these different directions. Okay, next slide, please. So I'm here to talk about telehealth today, and Dan and Lisa, I think, provided some really great comments and a lot of expertise. So what I'm going to try to do today is really just talk a little bit about what we've seen at NASHB in terms of how states have been thinking about telehealth during the pandemic and following the pandemic. So just to take a step back, like states, serve different roles in thinking about healthcare. They're payers, so, they regulate their Medicaid program and run their Medicaid program, their state employee health plan. And if a state has chosen to run its own marketplace, they have that population as well. But they're also regulators, consumer protection in terms of privacy, fraud, advertising, patient choice, and self-direction. And so they're balancing all three roles when they're thinking about sort of the future of telehealth. And I'll just say, I've been in state health policy for now, 15 years at least. health policy much longer than that. And really the impact of COVID-19 and the federal public health emergency, Lisa and Dan talked about this. It really can't be understated. So, we had these lockdowns and there was a need for, as we all know, to really figure out what to do with telehealth. And states prior to COVID had flexibility, for example, in their Medicaid program to think about different ways to pay for telehealth services. But many states had strict requirements for technology and originating sites, and it really limited utilization and access. On the Medicare side, Medicare only paid for telehealth services under limited circumstances. And then employer health plans sometimes covered telehealth, but utilization was low. So we now have a whole different sea. I feel like we made, 15 years of progress on telehealth in the span of 2 years, just because we had to. And along with that came change in consumer expectations, change in provider practices. And I know you've talked about sort of those pieces in the prior discussions you've had on this topic. But when we think about sort of what's next for states, I thought we could talk a little bit about what did they do during the federal public health emergency and how are they thinking about making that permanent? So we can go to the next slide, please. So states did a lot of different things. They had flexibility for the way you could actually deliver services. So Zoom, audio only, these were things that states didn't do before the pandemic, but many, if not all, actually did that during the pandemic. They actually thought about text-based communication, remote patient monitoring. Patient homes are originating sites, so changed the whole basically way that they thought about being able to pay for telehealth services, which was very uncommon prior to the pandemic. States also implemented temporary payment parity for telehealth and in-person services. And now 21 states are implementing payment parity on a permanent basis, with 6 more sort of moving towards that for certain services with a specific sunset date as of now. And state expanded the services and providers that were eligible for telehealth, including areas such as behavioral health, which I think we saw was immensely important and critical in serving the needs for people who had mental health crises as well as substance use disorder, with the being able to prescribe things like buprenorphine without having to have an in-person visit. States also relaxed and waived requirements for in-state licensure for providers offering services by telehealth, or, as Lisa talked about, granted temporary licenses for out-of-state providers during the pandemic. Okay, next slide, please. Keep going. So I think now we're at a point where some states are deciding, okay, the federal public health emergency is ending in May. Some of the flexibilities will continue. For example, Medicare is extending their telehealth flexibilities for 2 more years. But states are deciding, do we make some of the changes that we did during the pandemic permanent? And I thought I could just spend a moment talking about the decision points that different states are facing. And as Ativ sort of talked about in the beginning, it isn't sort of one way that's sort of predominantly the way that all states are approaching this. There really is a lot of differences, both at the state and regional level, of how they're thinking about how to make this permanent. And Shan's going to talk about North Carolina, but I'll give a broad overview of what we're seeing across the states. So a couple of things that they are thinking about is definitions. So really glad to hear, Lisa, that you have a definition that you all have put forward on how to define telehealth. Within state conversations, between their executive branch and their legislature, there are different definitions that are being considered. Is it, what are we thinking about with online portals, video visits, audio only? States have had different conversations and different approaches as they think about what to make permanent for each of these. Access. So there's a lot of thinking going on about what is the patient and provider capacity and willingness to use telehealth services. I think we saw such a surge in the use of it, and clearly it's here to stay, but different populations have experienced it differently. And I think we've seen some states reporting to us that, for example, in rural communities and communities of color, there was not an equal use or equal offering of telehealth services. So I think there's thinking around, how do we make sure that we're going to be addressing equity as part of our decision to move forward on a permanent basis with telehealth. Quality broadband. So just to talk about that, that's a limiting factor, particularly for rural areas. It doesn't always apply equally in different parts of states and different parts of counties if a state has counties. So, a state like Illinois, for example, requires reporting on whether telehealth medicine is improving access, reducing health disparities, or promoting health equity, because they want to continue to learn and really evaluate about what is the impact on access of sort of moving to this. There's questions around network adequacy. So in a Medicaid program, for example, or state employee health program, are you going to deem a plan meeting network requirements with telehealth? And there's, pros and cons to think about that. It's great to have more flexibility. We need more, we don't have enough providers. But how do we make sure that we ensure that there's equity and that plans are actually providing in-person services when a person needs it? So states are balancing those considerations as they think about what to make permanent. And then there's payment approaches and thinking about, okay, do we continue with payment parity? As I mentioned, there's about 27 states with parity. There's more states considering how to approach that. Some state Medicaid agencies are putting parameters around parity and some additional requirements to really ensure quality and looking for certain types of outcomes. And then there's also balancing cost. So I think there's potential to improve efficiencies and lower cost and expand access to care, quality care with telehealth, but there's also, I think, considerations about how to do that effectively and making sure that in the long run, we're going to really be improving care for the populations that states are serving. Okay, so what have states been doing in 2023 so far? So next slide, please. So there's a couple of things, and we expect, so we're, states, unlike the federal government, many states have limited legislative sessions. Some have year round, but the majority, end in March, April, May. So there's a limited time to really get all of sort of that work done. And state action so far in 2023 has been interesting, and there's more to come this session. So a couple things, there's clarifying definitions related to telehealth in states like South Dakota and Massachusetts. There's expanding access to prescriptions through telehealth in a state like Virginia. There's joining interstate compacts that you heard about earlier from Dan. Wyoming and Virginia have decided to do that this year. There's flexibilities for out-of-state providers with Virginia, New Jersey, and Illinois. There's thinking about how do we expand services for telehealth. And there's some states that are thinking about occupational therapy, physical therapy, and speech language pathology. Texas is a state that's thinking about that passed legislation. South Dakota's speech language pathology. Ohio is expanded to intensive home-based treatment. In North Carolina, which you're going to hear about more, behavioral analysts and medical nutrition therapy. In Missouri, there's a pilot program for teledentistry in nursing homes and long-term care facilities. And there's dental audiology and vision in Kentucky and acupuncturists in Oregon. So I just wanted to paint that picture of, I think there's a lot more that states are considering, but it's really not, it's fluid. I think there's more data that states are analyzing, what they've learned during the pandemic, and how they're going to continue to use that data to figure out what to do on payment and providing access moving forward. And then just next slide, please. This is just my contact information, and I'm looking forward to the discussion. So Ateeb, I'll turn it back to you.
Well, thanks so much, Amy. And then Shannon, love to hear your perspective from North Carolina.
Great, thanks. So we started at the very high level of what was happening at the national level, and then Amy gave us a snapshot of everything at the state level, and now we're going to drill down to a state, and I'm going to tell you a little bit about North Carolina and what's been going on in North Carolina. Now, if you've seen one Medicaid state, you've seen one Medicaid state. And so just to let you know what North Carolina is like compared to other Medicaid states, we have about 3 million beneficiaries right now in our Medicaid program. And we are a non-expansion state, although for the first time ever, it looks like we might get expansion, but fingers crossed. But that's just sort of the lay of the land in North Carolina. If you go to the next slide, right before the pandemic happened, we had one telehealth policy in North Carolina, and it was behavioral health, and it was for a medical home to be the originating site and psychiatry to be a distant site. And so it was not utilized a ton, but it was utilized. About 3 months before the pandemic, then Assistant Secretary Ben Money and I put together a telehealth work group, and we projected a 3-year runway to turn on the things that we wanted and get the legislative authority and all the stuff we thought we'd have to do. And instead, we did all of that and more in 6 weeks, just a few months later. So we had this rapid modernization of our telehealth platform. And what that meant in North Carolina was that at first it was slow because providers hadn't been able to do telehealth. But as they picked it up, they really moved beyond the telephone and went into real-time audio visual. And we saw our numbers go up. And then you can see in the call-out box, the numbers have gone down, and which is what we'd expect as more people are going back to the office and out in the world, they're going in person for care. But the question for me is, have we gone too far down? You know, and do we need to swing the balance back a little bit? If you go on to the next slide, I just want to show, I'm going to show you a few just really high level slides. This is just a look at adults and children and whether they were engaged in telehealth before the pandemic or not in the behavioral health space. Because remember, that was really our only space we had. And what we found was that the dark green bars are those that were engaged in telehealth prior to the flexibilities being put into place. The dark orange bars, they were not. And the next bar next to those, the lighter colors, shows that did they stay engaged in care during the pandemic. So telehealth users stayed engaged in care. Non-telehealth users were engaged in care at a much lower level, even when they could use telehealth. So we found that to be a nice finding. Next slide. This is our CAP survey on telehealth, and this goes to my point earlier about have we swung too far away from telehealth. This is beneficiaries where they offered telehealth in the prior 6 months instead of an in-person visit, and only 26.7% were even offered telehealth. Of those, the majority said, yeah, I'll do telehealth, you know, with occasional declines. But what we're seeing is that practices are going back to business as usual and not necessarily incorporating telehealth in the way that they function across the board. But we're finding our members are more interested in using telehealth now than they were 2 years ago. So they're getting more comfortable with it. Next slide. So the next two slides, this is adults, the next one's children. We have spent a lot of time studying and understanding going back to day one, when March of 20, when we turned on our first telehealth modernization flexibilities, looking at Black versus non-Black, Hispanic versus not Hispanic, rural versus urban, and then those with chronic conditions and without. And what we have seen is persistent inequities in access to telehealth, particularly in the Black and the Hispanic population, where we don't see significant improvements over time. In the rural versus urban, there's inequities. Rural are not accessing telehealth. So this sort of promise of telehealth overcoming inequities is sort of make-believe right now. That's not what we're seeing in North Carolina. Is it improving? A little bit, but we're still not in an equitable place. Those with chronic conditions really use telehealth early on, which is great. That's what we wanted to have happen. Using it a little less so as time goes on, and that's probably okay as well. The next slide shows you the same data looking at children, and you see a little bit better patterns of improvement, but you still see the inequity persisting in the Black, Hispanic, and rural populations in North Carolina. Next slide. So this is our CAPS response, which I find incredibly telling. And what it tells us, bottom line is that our non-white members are offered telehealth at a much lower rate than our white members, and accept it at an even higher rate. So they are interested, they would like to be using telehealth, they're not being offered telehealth. So there's some implicit bias or something is happening on the side of the practices about whether or not they're offering telehealth services. Next slide. So in preparation for this, I sent out a plea to the CMOs of all the Medicaid programs in the country. We have a listserv where we go back and forth on things. And I got about a third of them to respond to this. And I asked them the question of, did you offer out-of-state remote only providers reimbursement for telehealth during the public health emergency? And you can see the vast majority, over 3/4, did. Do you plan to offer it in your permanent policy after the public health emergency? And you can see it's half-half. So about half are saying, yes, we're going to continue to reimburse out-of-state providers for telehealth services. And half are saying no, or maybe. And that's, I think that reflects Hamy's comments about there's a lot of variability around the country. So the next slide, I asked them, well, why not? Or if you are, even if you are, what is your number one concern? What is the thing that kind of keeps you up at night, worried about out-of-state telehealth services? And number one across the board, no question, is that potential for fraud, waste, and abuse. And I think probably what comes with that is that we don't know how to audit for that yet. We don't know how to track for that. And the big fear with telehealth, the reason North Carolina hadn't expanded prior to the public health emergency, was this fear of cost. We thought it was going to be duplicative. We were going to break the piggy bank of Medicaid. But that's not at all what happened. So we've gotten rid of that myth. We busted that myth. Telehealth is not breaking the piggy bank, but we don't know yet how to look for fraud, waste, and abuse. And so we're starting to do audits now to try to get a better understanding of that. The other number two, which followed shortly behind the fraud, waste, and abuse, was the inability to provide hands-on care when it's indicated. And so this problem of if a provider is only available out of state, sometimes people need hands-on care and there's no way to give it to them. So are we going to have the same quality of care? Are we going to increase low value care in lieu of high value care? Are we going to send a bunch of people to the emergency rooms? There's all these questions are sort of sitting in the minds of your medical directors in Medicaid states. So only 1 out of 15 respondents said they had no concerns with telehealth. So that was sort of interesting. And by the way, this represented North, South, East, West, Midwest, rural states, urban states, blue states, red states. So it was actually a nice smattering across the country. All right, my last slide, and I will tell you where we are in North Carolina right now. We are definitely trying to get the genie back in the bottle. So we were broad with our telehealth expansion because we wanted to make sure people had access to care. In June of last year, we announced what our permanent clinical policies were going to be, using a whole lot of different criteria to establish that. Every now and then we're flipping things and saying, okay, maybe we were wrong, maybe we were too restrictive, let's open it up. But we're trying to get the field used to what we're saying is our permanent policy coverage. We feel strongly that care needs to be anchored to the medical home. We feel strongly that it's important for providers to offer an in-person option. And so that's actually required in our clinical policy right now. You can't force a beneficiary to only do telehealth. If you're going to be serving them, they need to have the option to be in person if they want to be in person. And we're trying to learn how to monitor for fraud, waste, and abuse and what that's going to look like. The last thing, which I think is super important for all of us, is what other policy levers do we need to use to make sure that we're not accidentally exacerbating health inequities with telehealth? By that, are we pushing telephonic care, which I would maintain is the lowest value care compared to real-time audiovisual, compared to in-person? Are we pushing telephonic care to people who don't have access to minutes on their devices, who don't have access to broadband in their homes, who have lower digital literacy, in which case we're going to make health inequities worse. And so how do we make sure that we are fulfilling the promise of telehealth, which is to overcome health inequities, except that is not what we're seeing in North Carolina, and I think what other states are seeing as well. So when we put it all together, how do we make sure that rural and urban have equal access? How do we make sure that white and non-white have equal access? And how are we being consistent in how we offer telehealth to the beneficiaries? So that's what I've got from North Carolina.
Thanks so much, Shannon. This is great. And if the panelists could put their videos back on in the last 13 minutes or so, we can ask some questions here. Maybe I'll start with Dan. And, you know, these compacts, as you alluded to when you went through them, look extremely different. I wonder if you could comment on their success, and if success was measured as the number of their, you know, given discipline or clinician type who are actually signing up for those compacts. Is there a clear difference in that metric of success?
Yeah, I run into this a lot. I mean, there's not a lot of data on compact participation. The nursing compacts engaged in some research now. The other ones haven't been operating long enough that I think they would have valuable input on that front, but I expect that to come as they mature. They're all fundamentally the same, though. They all work the same. They all preserve the state's ability to regulate the profession within their borders. You know, the state can act against that practitioner, you know, as long as, you know, they're practicing in that state, they can take action against them just like they would any other practitioner. One of the things that we have seen is just anecdotally is if a practitioner has multiple licenses, you know, they will immediately go to a compact privilege or a license. If they've only got license in one other state, it takes longer. So I don't think, I'm not going to sit here and tell you that, you know, they've solved all the problems, or that, you know, they've you know, solved the problem of access to care. But I believe that, you know, the more they mature the more practitioners use them, I think the more that you're going to see patients rely on practitioners utilizing that compact.
That's really, really helpful, Dan. Thank you. Lisa, maybe turn to you. One of the issues that comes up, at least I've heard, and I'd love for you to comment on this, is the conversation at the state level of if one of my residents of my state has poor care provided by a physician in another state, how do I ensure that I can, protect my resident? And I wonder if you could speak to what has been the experience so far with the IMLC and others across state in terms of regulations, and also just generally what the process is. I think there's a little bit of a lot of people don't really understand how state medical boards talk to each other.
Well, they do talk to each other in a number of ways, but in the if anyone can file a complaint, right, with another state board, as long as you know where that person holds a license. It can be complicated, and a number of there are a number of situations where a remote state can take an action. And most states, in fact, I believe just about every jurisdiction in the country has, they can take a action based on the action in another state. And so the problem with that, there has to be an initial action taken. If there hasn't been an action taken, and that there are some complications for the remote state to be able to investigate, it has to do with issuing a subpoena, also as to travel to examine any kind of facilities, and whether how that there is no really long arm jurisdiction in those cases. Now, the compacts do address this. All of these compacts have a system in place that will allow, with the IMLC, it allows joint investigations to occur. It allows them to share information that would otherwise be confidential just among the compact participants as far as complaints and current investigations. So with all of these compacts, they have tried to build in some of that where there is a better safety net, if you will. So if something happens in one state, that there is a period of time, there's either some sort of automatic suspension or discipline while the other states have a chance to examine that. But so the system is if they're not a member of compact, there is some hurdles in investigating a physician that is licensed in another state.
Well, that's really, really helpful. Thank you, Lisa. Amy, one of the things you touched upon in your presentation that I thought was really important was definitions and what the heck we're talking about here. On the first panel we had in our series, one of the physicians really described how the focus on telemedicine and licensure has raised questions about things that physicians have been doing for 20, 30 years, which is calling their patients back in another state. And is that practice of medicine? And am I breaking the rules if I call my patient who goes to another state? I wonder if you could speak to whether you're hearing that kind of question come up in the different state legislatures, and how are states maybe responding to that, this newly discovered problem, if it is a problem, I don't know.
Yeah, no, I mean, it's like, is telehealth going to continue as audio only? So could you literally be in another state and just be communicating with your patient on the phone? And is that going to be paid in the same way as a regular in-person visit will? And I think that a lot of states are grappling with this, because a lot of them said, yes, of course, like Shannon talked about this, like during the pandemic, we want to make sure people have access. A provider's gone to a different state, the patient's in a different state, people have been moved around during the pandemic, they're not going in person. Of course, like, let's make this audio only, something that, people can get care and get, in touch with their specialist or whoever else they're seeing on a regular basis when we can't come in person. But now I think it's a different question. And at least I think it gets into sort of the medical board piece of this. Like, is there going to be enough oversight for those audio calls? Is there going to be enough quality and ability to provide the services that that patient needs? It's really interesting. I was just looking actually at two states that just passed some legislation, Illinois and Oregon, And the legislators in those states were really worried about, like, oh my goodness, if we go to audio only and telehealth only, the patients will lose access to in-person services. So they're prohibiting insurers from requiring that patients use telemedicine when the patient prefers in-person visit, so that to make sure that the consumer has a choice. And I say that because I think from an insurance perspective, and for some providers, telehealth is sort of the new way to be able to do business. And there's a lot of good in that. You know, I don't think it's a negative, but I think there's concerns from sort of an oversight and consumer perspective about whether we're really going to have the right balance. So another just interesting tidbit on that note is, like, Arkansas is basically saying insurers, like, you know, don't incentivize your people to go to your patients to go to telehealth. You cannot charge more to see a network provider than you would for a dedicated telemedicine provider. So that can't be the default for telemedicine, phone only or whatever that may be, which, you know, you'd have a lower copay, and then you have to have a higher copay if you went in person. So just to give you a flavor of some of the debates that are going on to make sure we're balancing access.
Yeah, no, it's a fascinating thing. One of the things I've been seeing in terms of discussions is follow-up care. A patient sees me in person, they go home, they send me a portal message saying, hey, I wanted a follow-up question. Am I allowed to do that anymore? At least physicians are starting to think about questions that they never really had addressed. So Shannon, wanted to turn to you. One of the things that, and I know you can't speak to the folks that responded to your email and so forth, exactly all the details, but one of the questions that came to my mind as you were describing their response and their concerns about fraud, waste, and abuse of out-of-state clinicians via telemedicine, is your sense that it's a telemedicine concern, or is there a real distinction between telemedicine from out-of-state physicians or clinicians versus in-state? In other words, are the concerns about fraud, waste, and abuse truly a state border issue, or is they just generally with telemedicine?
I think it's probably a both and, actually. So there's this concern. There are a lot of, you know, venture capital funded startups all over the country that are really aggressive in getting coverage and getting in front of people. And so are we going to be getting high quality care? Are we going to be duplicating services? And what does that look like? And that would be an out of state question, especially when you have these national companies who are trying to ping everybody everywhere and build up their panels of people. Versus, so are you going to duplicate services? Are you going to get the same service here and there? And how do we watch for that? There is the broader question instead, like, just for any at all, like, how do we monitor this? Like, the E&M coding system, is crazy as it is, it does have really clear parameters about what you need to do and how you need to do it to bill and to code certain ways. If you can't do a physical exam and vital signs, like, a whole section of those requirements is off the table. And then if it's a phone call, do people even have, there's all these questions about how do you measure it? So back to the question Amy just answered was around the audio only. The way North Carolina handled it is because we didn't have telehealth before and our providers were really, like, not used to doing telehealth in North Carolina. We decided, we saw so much the telephonic numbers went straight up, just this exponential rise. We said, actually, we're going to reimburse telephonic at 80% of parity. And so we did real-time audio visual and in-person at parity, but audio only at 80% of parity. And as soon as we announced that, which was about 6 weeks in, so we gave people, you know, a little time, all of a sudden the real-time audio visual numbers started climbing. And so we just saw an immediate reaction to that. And so I do think there's value in a phone call. I've had many phone calls with my patients that I've never been able to bill for before. That's real value. That's me providing a service as a physician. So we should be paying for telephone calls. We should be paying for portal messaging. There's all sorts of things that historically we've not paid for, which undoubtedly contributes to the burnout that we see in healthcare. So it's just that balance of how do we pay for it and how do we make sure we're driving people to high value care.
I think we're almost on time here, but let me just try to slip in two questions, one from the chat Q&A and one for others. Maybe I'll start with one question that's come up a lot. Dan introduced the IMLC, Lisa showed the great map, and there is this question of what's holding up the other states. And I don't know I wonder if you could speak to that. There's obviously some parties that are anti the IMLC, and I wonder if you could kind of describe a little bit of their concerns and issues.
Well, and Dan can certainly add on to this, because I think we've seen, there are some states that just seem to not be interested in either the nursing or the medicine and just a little bit anti-compact, if you will, as far as the health professions go. We were encouraged that, Massachusetts now has the bill introduced. I think we're seeing some of that in New York. There's some movement there. This bill introduced in New York. Once Texas was a big add-on to the IMLC, and really brought lots of physicians into that, and they were I really that there is a number of reasons of whether whether it's the medical societies that are going to oppose joining the compact. And I think you have to just look at the politics in those individual states as to why they are not interested in moving forward with the compact. But we have certainly seen a lot of those states that we were concerned would not join, really have some interest in it. And we would like to have those large states joined.
So, well, I have so many questions, but I think we're out of time here. So first of all, let me give a big thanks to all the participants and the presenters. A really amazing presentation. Learned quite a bit. And thank you all for the participants also for your questions and your interest in this topic. So thank you again.
Thank you.
Thank you for having us.